Ken Harris is the head of academic medicine and state local government healthcare for providers for Amazon Web Services. His team includes principal trusted advisors in digital health, hospital modernization, precision medicine, clinical care and informatics, and health tech sub-verticals, as well as field-based and customer-facing healthcare executive advisors. He has over 30 years of healthcare experience, including founding and taking public a cell and gene therapy company. Prior to joining AWS, he was a chief clinical officer, president, and CEO for 10 years. Ken has a strong background in building and commercializing regulated products in the device, combination product, clinical software, and therapeutics biologic space. It is truly an honor to welcome him. And I'll just say, we're going to try to be a little more on time than we were yesterday. And so we have a team who's going to be giving our speakers a 5 or a 1 minute warning. And then we are going to make time for questions. And so we have both microphones on both sides, and you have to be at a microphone before you ask your question. Thank you.
Good morning, everyone. So I want to thank CBTN for inviting me to give the keynote. It's an interesting, when Adam mentioned that he would like for us to do this, I was thinking about what's my message? What's my message to researchers and to clinicians and to patients? I think my message is that we have to change incrementalism. So I'm going to start with that theme. And incrementalism is really, if you think back to driving your car and where we were 20 years ago or 25 years ago and getting from point A to point B, let alone trying to get to a cure. We used, in the year 2000, we had very nice atlases that were on paper. And those atlases had complex roads and complex directions. But I don't know about you, if I would open that atlas and I wanted to go from, LA to New York, I wouldn't know the exact way to get there and the fastest way to get there. So I would go in and plot probably the biggest highways or freeways and plan my path that way. Today, Google does that for you automatically. And it calculates the methods for you to get there. It calculates the time. It gives you options. And it even gives you very precise information 3-dimensionally as to what your surroundings are going to look like. All of that on a phone. That is exactly where healthcare needs to get to. And although incrementalism, and I think the slide showing all the areas that we need to understand and do more research in, leading to big compute and analytics is really, really important. And we do have to understand every one of those roads. And we do have to understand that getting to your house, you can go through the alley, you can go on the main road, you can walk. How do we do that at scale? And that's what I'm going to talk about today. So how many of you, just to start off the morning, think that you have the data you need to answer the questions that you want to answer? Just raise your hand if you feel you have sufficient data. Okay. How many of you think the data exists that you want, but you don't have access to it? Well, that's an interesting question. I'm surprised by the answer. So you think the data doesn't exist in some way or another. That's probably true. There's a lot of white space out there in biomedical research, but my guess is there's a lot more data that is in the world that you don't know about. And that's the first thing we have to unlock. So as a technology company, I think our problem, and I love this quote from Charles Kettering, is I think we understand what the problem is. The problem is access to data, and it's unlocking what the data is telling us. So how do we do that? Well, we're going to have to do that with technology. And, I think my personal opinion is I think the federal government and the granting programs are designed to give incremental support. They fund an individual project. The individual project tells you to walk through the alley to get to your house. But it doesn't tell you that you actually need to go to that house to solve a question. And we have to get there with infrastructure. So at Amazon, I joined Amazon 3 years ago, having come from the industry side of things, really because what I saw in my last startup in the area of gene editing in the brain was I couldn't do that in the wet lab, and I couldn't do that with scientists wanting to go in and solve one question at a time. We had to use that with massive computation analytics. And we did that at Stanford. And it was a very interesting process. And it showed us insights that were almost unbelievable to me. I was kind of an old dog trying to learn a new trick, and I realized that I didn't understand really a lot about large analytics and large computation. And so at that point, I felt I was using Google at the time. I felt that I needed to understand hyperscaling in an analytics world. And so I landed at Amazon, which I think is the best hyperscaler and best analytics company in the world. So how many of you go on to Amazon.com and the recommendations on Amazon.com were things that you were thinking about, but you never remember Googling? You never remember talking about, but somehow those sneakers that you were thinking about at dinner last night that you probably needed to go out to buy shows up as a recommendation on your homepage. That is the power of analytics, and that's the power of AI, and that's what I'm going to talk about today. So I think we understand the problem statement. And I think the problem statement is that, even adding more and more data, and even if we add more and more quality data, how do we handle and compute that data? We haven't solved for that yet. And I think that's one of the biggest tasks. And I'm going to suggest that that's going to require really some sort of a czar or an oversight organization that thinks about the big problem we need to solve in oncology, and in particular in pediatric oncology. And that's probably, as shown on this schematic in the left-hand side, is really about developing an IT nerve center that's in the cloud locally, and an IT nerve center that's in the cloud regionally, and an IT nerve center that's in the cloud across the globe. And we're going to do that by integrating lots of really simple levels of information: hospital information, the EHR data, the laboratory information, the public health data. And I want to take you beyond thinking about just what the cell is telling us at the moment, but really go back to a lot of other elements in big data that are important for us to understand to actually solve some of healthcare's most challenging questions. And the fact is, I call this the 4 I's. Big data isn't just unlocking the electronic health record. It's not. Electronic health record, we have known since, really came to fruition in 2014. We've known that it's bad information in, bad information out. It's all down to the individual clinician who is putting in the information as they see fit in that 20-minute engagement. And ultimately, that is the information that everybody thinks they want to go mine because it's some gold pot that's going to tell them the answers to this disease. It is not. We have to be a lot more structured, and we have to cast the net of data that we're looking at to understand disease a lot broader than the phenotype of a patient, and a lot broader to the biochemistry of the cells, and really get down to what's the causation of the disease, what is the phenotype of the disease, what do we need to do about the disease? Interventions therapeutically may be the right way to go. We've thought that a long time because pharma convinces us that that's the right way to go. But there are a lot of other interventions we can do earlier on. What's the causation of the disease? Is it environmental? Is it social determinants of health? Is it behavior-based? We don't know all of that. So we really have to go broader than what an individual lab can answer on a biomarker, for example. And then ultimately, as we think about pediatrics, most of this work, even if the net's cast very broadly, is done in the adult world. It's not answered for pediatrics in dosing, toxicity, the 5 stages of pediatric patients. A neonate is not an adolescent. Those are 2 totally different phenotypes. And that makes pediatrics really, really complicated. And so one of the things I love about being here and participating in this project along with you is the fact that we can start to bring our capabilities in big analytics to capture as much of that data and aggregate it as possible to unlock it for you, to ask the right questions. So who are the stakeholders? And, broadly, even in this room, I think we have patients and families, we have clinicians, we have researchers, but we're also lacking a lot of the other stakeholders that are interested in the outcome. And that's the reason why, if you think about this map as a whole, the reason we need more of ZAR that's coming in and taking an industrial approach to specific questions and outcomes, because the interconnectivity and the 6 degrees of separation are broad, and there's a lot of different data sets out there that are going to be important to asking these questions. So, drilling down into the pediatric data problem. So we have all of these different stakeholders and elements involved. And then the next question is, well, okay, do we have adequate data sets? No, we have to do a lot more research. We have to fund those research, whether it's in biomarkers, phenotype, environmental data, et cetera. But then we have to figure out how to connect them, and we have to figure out how to analyze them. The connecting part really I see as being a job of someone like an Amazon or a Google. We can figure out how to bring the data together. We can figure out how to drill into the data as it is locally, and we can even build software to do large analytics. But what we can't do is teach the people to do the analytics. That is really up to the academic world. If you think about the number of clinicians today that can run bioinformatics, it's alarmingly low. And next year, the University of California is launching the first medical school incoming class that bioinformatics is going to be required, 2023. Now that means 2027 to 2028, we're going to have clinicians, young clinicians coming out on the other end that will have been exposed to bioinformatics for the first time. How can oncologists and parents and researchers talk about using large data if the practitioners don't even know how to use the data? And we've got to address this really, really quickly. And that's one of the things I'm proud about Amazon. As we're leaning into this, we have agreed to train 20 million people in informatics across the globe over the next 5 years. And in precision medicine alone, our goal is to train 1,000 new research scientists and clinicians on bioinformatics in the next year in the US. And we've got to just drive that really, really quickly at the same time in parallel that we are building software and the infrastructure to allow data to even be computed against. But I'm going to show you kind of, this is how data is computed today. And I put up there kind of a snarky comment that it's so yesterday. And it is so yesterday. But the fact is, we all live this every day as patients and as consumers, is that, conceptually, we're all out there to grab the EHR data and aggregate the EHR data into rows and columns. And somehow those rows and columns are going to unlock the secret of an individual disease, longitudinally looking at multiple patients in a data set. Has it happened yet? No. And I would say that the scientists that have been working on this are equally as good as the scientists in the last 50 years. But no one solved this problem for most of our diseases. And so we can continue to hit our head against the wall, or we can think about approaching data in a completely different approach, which is really the multi-omics. It's going back to Google Earth, and it's taking that flat map that you have to look at to decide how to get from, New York to California on your own, and it's using analytics to ingest and aggregate with machine learning to look for the signals in the clustering that are signals of importance. And if we don't know the right question to ask, or we are asking the wrong question, we will never, on the previous slide, get to the right answer. Because fundamentally, we are erring on the first question that we ask. As we start to think about unlocking machine learning, it will find those clusters. And then human intelligence can question the discovery of the cluster to say, is this a good signal? And what does this signal mean? And I should really lean into this. So it turns the paradigm on its head. Versus asking a question, we let the data tell us what to ask. And this is part of what Amazon is building today. We're taking that, shoes recommended for you on your homepage on Amazon.com, and we are creating that in the healthcare environment to be used by academic medical centers and providers and research institutes. We never aggregate your data. We never look at your data. We don't have access to it. We just build the infrastructure and the vault that makes it available to the healthcare world as a whole. And this is a good picture of what really has to happen to understand at a macro level what is taking place in an individual disease state. We do have to understand, the raw data sets. We need the raw data sets. We should not over curate data from the raw data sets in the very beginning because we haven't even looked for the right signals. So we're a big believer in creating large data lakes of data, part of what, for example, CHOP is building for the CBTN, and that is an excellent place to start, and let the data walk you to the question to ask. But even beyond that, you've got to get beyond the patient and actually understand, even if we have an identified biomarker that's therapeutically interesting, there's so much more that's involved in the outcome of the patient than just, did we give them the right treatment? Did we give them a treatment that was properly manufactured? I put in the bottom GXP bioprocessing data. And I'll give you a real life example, having come from the cell and gene therapy side of the world. Most cell and gene therapies are unknown of their quality by the time they're infused into the patient. We know maybe how long they stayed on the shelf, but we have no idea that it was produced exactly the same as the last one that worked because we don't have the analytics built in. So I'm here to challenge that you've got to go way beyond just the target therapeutic, is you've got to understand the entire 360 degrees around precision medicine that is beyond just the biological question. Genomic data is another interesting area. Going back to the EHR, another challenge you've got to look at the data in its raw form, is flat file genomic data in EHRs is already information from which we think we know the answer. But we're not really out there looking. I mean, how many of you, if I came up with a new drug tomorrow for a particular indication, would be able to go back to your database and actually pull out a cohort of patients that would be on target for that treatment quickly? I would say almost none of you, because that level of bioinformatics is not yet built into your system. That's our responsibility. And our patients and the families expect us to be able to provide them that kind of access and that kind of timely response. So again, going back to bioinformatics, I would say one of your key pillars in building a data strategy is having your bioinformaticist and your data lake and systems in place as early as you can get them. So what are we doing about that? From an AWS perspective, we are now starting to look at what's needed in this broader ecosystem. Well, we know first and foremost, security and privacy is critical. Even though for the CBTN, which is a very unique data set, there's full consent for research applications and availability for mobility of data and moving it outside of its governance four walls. But security and privacy is still important for everyone. So first and foremost, we have to deploy in healthcare what we already know in banking, what we already know in guarding the US's nuclear weaponry, which is all run on AWS or in the cloud. We have to deploy that into healthcare. And another question for you, how many of you have heard people say that the cloud is not secure for healthcare? I hear it every day of my career. Well, we can't go into the cloud, that's not secure. Or Amazon is mining my data. Amazon doesn't have access to your data. You hold the keys. It's encrypted in a way that no one else can see it. But what we do have are thousands and thousands of security professionals working 24 hours a day to ensure that there are no intruders coming into the data or bad actors. How many academic medical centers have 1,000 security professionals working on their on-prem systems? None. So again, that's the scale of architecture. Next level of development that we have to figure out how to work, and we are not there yet, is in federation. So moving data is simple. We can aggregate data into one large data lake. That's not ideal. It's also time consuming, it's expensive. So we need to establish means with which we can compute against data sitting in multiple silos across the globe. So it's really a hub and spoke based approach. And I think federation is kind of the last frontier for us to solve before we truly unlock dark data in healthcare. And we're not there yet. And one of the projects that we will be undertaking with Children's Hospital of Philadelphia is to start to even automate being able to go out, and I'll use this example as a robotic arm, being able to go out and grab the data at all of the different sites and pull it into an aggregated platform. Even that is challenging. And we're running it as a proof of concept now, but it's the first step to federation. Once we're able to aggregate the data, grab it, move it, then we're able to start building the software tools that can compute against it in place. Another interesting area is starting to think about, back to the 4 I's, looking at families and hereditary data that isn't specifically to the patient. Is thinking about data from the wild and information that people can put in to help us unlock what we don't know. And when did the symptoms start? Or will I develop the cancer that my grandparents had? All of these types of things are really interesting in the broader picture of oncology. And consenting to that, unlike with the CBTN that has phenomenal consenting already in place, data from the wild has a lot of barriers to aggregation and consenting, withdrawal of consent, deletion of data, for example, that's now required in California. If I decide that I don't want my data to be used, it's not only not using the data, I'm responsible to go in and delete the data from wherever it resides. So these are another area from sort of infrastructure that has to be developed. And we're starting to get there, but we're not there at the moment. In the US, we have roughly 15 to 17 regulations that you have to comply with to actually move and consent healthcare data. Machine learning and analytics. This is really probably the one we all think is the most exciting, and it's where really the rubber hits the road. How are we going to deploy machine learning off of biased data sets? And what is the risk of machine learning actually giving us a lot of wrong answers? And I saw a really good picture of this last night using natural language processing, where you ask in layman's terms a question to the model or to the algorithm. And the question was, can you show me salmon in the river? And do you know what the machine learning, the algorithm came back with? It came back with pictures of salmon fillets floating in the water. You know, it's a very simple way of thinking about errors that machine learning can make, but it only knows what we show it, and it learns from what we show it. So biased data is a big risk for us in healthcare. And it's one of the reasons, for example, we have not solved sepsis with machine learning. It's a complicated disease. Cancer is a complicated disease, and I am not here to tell you that we are anywhere close with machine learning in the space, but it's trial and error. Test it, test it, test it, and see whether we can actually get the salmon fillets to look like fish, whole fish, and then let them be alive and let them be doing what they do in their ecosystem. We've got a long way to go, but we're working on that every day. You're working on that every day in your labs and in your institutions. But if we don't build up our capabilities from the number of people that understand how to build algorithms, we won't go fast enough. So if I leave you with one message today in thinking about what is our barrier to big data in healthcare, it's skill set gaps. We don't have enough. And we don't have enough people across the globe that are deployed on the right questions. So absolutely important. And then finally, even if we had great models that were doing predictions, we have to be able to explain that to people in a very simple format and to the individuals that are on the front line, the clinicians. We have to make it visual to them. We can't expect them to go in and understand in all the different diseases what the data is telling them. We have to make it visual. And that's one of the other areas that we're working on at Amazon is we're really trying to drive that reporting structure to say, hey, this is what it looks like. This is what's important. And these are your options as the human intervention side. So where we want to get to first. So I've laid out a lot of challenges, and having been doing this for 3 years, for the first time, I think with the Children's Brain Tumor Network, we have an opportunity on a very small scale with almost a perfect environment to start to challenge our team in developing the right infrastructure and software to understand if we can build code and get answers on a curated data set like you guys have. That doesn't exist anywhere else, and we're excited to lean into it. We're going to be doing the first proof of concept with CHOP in early Q1 of 2023, where we actually go out and see if we can grab the data from multiple sites and aggregate them. Next thing we're really thinking about is, okay, once we've done that with this network, what did we learn, and are we able to deploy AI ML around it? And I think probably that's where we're going to run into our second area of interest. And so my team is going to be focusing a lot on helping your organization with the AI ML algorithms and thinking about how to build them and test together. We need to learn as well, along with you, and to test our scientists. You know, I can predict right now, with about an 80% confidence level, a patient that's going to decompensate in the emergency department if I send them home for hospital and home versus sending them to the ICU. So we're getting there with certain indications with AI ML, but it's a very simple question. It's 80% confidence on a very simple question. Now, when we start to look at something as complex as cancer and so many different types of cancer, it's going to get more and more complicated. And so I think with this, as a company, you know, we have decided from Amazon's perspective that we want to lean in to healthcare as a whole. We do think that the system needs improvement, and the system needs improvement from delivery, from cost, quality of outcomes, and it's also financially not sustainable in the US on the path that we're on. So we've got to find a different way of doing things better and different. And, you know, I'm happy to say that we're committed to this project, and we're committed to understanding what capabilities we have and what things need to be built. And we don't have the answer to all of them. I mean, it's definitely, if you look at some of our, you know, recent initiatives and things like electric cars, there's a lot of room for trial and error, and we are happy to try that, happy to invest in it, but are in no way standing up here mentioning to anyone that we think that we have the answers. We just have the will to get there. And so this is part of our team that we got together a few months ago to kick off this initiative. And I think it's going to lead us a year from now to be here to present some really interesting data to show you what we learned from the initiative and what our next milestones will be after that standpoint. And, again, I'm just thrilled to be working with each of you. Hopefully we can expand our breadth and our depth to your areas and to your institutions within this initiative. And I think it's just blue skies with what we've started. So with that, I will say thank you.